fine.
Yeah, thanks for joining. So in 2-3 minutes we'll be starting. So I'll introduce Dr. Nalini Pati, and then followed by Dr. Achilles will have an introduction session, and then we'll start with the cases, and we'll finish off 3 cases preferably. After each case we'll have some focus discussion, and we'll take some questions from the panelists and delegates also. And if time permits, we'll take off 1 or 2 more cases like graft versus host disease, and then we'll wind up the session. So this is in a nutshell the today's agenda is. So basically I am from Apollo Hospital, Navi Mumbai, and also Achilles is from the same place. So it's wonderful to have you here in this session.
We have one more panelist, Dr. Srikanth Samavedan. He will be joining us shortly within 15 to 20 minutes. He said he's a little busy, but he would be definitely joining us. So till that time, we will start the program.
Yeah.
And hopefully, if we start in time, we will be able to finish in time as well.
Yeah, so I think in 1 or 2 minutes we'll be starting.
Yes, I think 45 people have already joined. So maybe we can wait for a couple of minutes. So Dr. Vikas, how is your experience of handling COVID in Dubai? How was it? Is it
Yeah, it was
controlled
good
now?
actually. It was very well supported by the government. All the consumables, all the medicines, everything was supplied by the government. All the PPE kit. We had to just provide the bed and isolation. That's it. But
Okay, all are vaccinated now, or
yeah. It's,
majority of the population is vaccinated?
yes.
Any resurgence of new variant? Any morbidity?
Not exactly. No, not right now. Here the mask has been removed. Now you can roam around in the open without any mask. Restrictions are not there. No travel restrictions.
How about the patients who are coming for ICU admissions in your center?
Sorry?
For the ICU admissions, how about the number of patients who are coming for the ICU admissions, COVID patients?
We had actually one of our hospital was converted to COVID hospital, where we had 2 COVID ICUs, and in those ICUs we had almost an admission of 238 patients in the first wave, and all the 3 beds we have around 500 patients, 550 patients we had.
Okay. Done. Fine. So Achilles, can we start?
Yes, absolutely, Dr. Gunadhar. I think we can start and.
So
yeah,
Anjana,
let's
by
go
the time, so Anjana, you are there. Can you load your slides by the time?
Hi, sir. Sir, actually, I'm getting a message that host has disabled participant screen sharing.
Okay. So Misbah, just please make Aparna M as a co-host so that she can share her slides. Okay, and by the time I'll introduce all the panelists here. Misbah, you are there? Can you make this Aparna M as a co-host?
Yes, sir. I'm able to do now.
Okay. So you just share your slides.
Okay.
And make it in the PowerPoint mode so that everyone can read. Okay. Okay, fine. So I'll just start. We'll just start the session. So let me. I'm Dr. Gunadhar Padi. I'm the consultant intensivist at Apollo Hospital, Navi Mumbai. I welcome you all to this academic session today regarding the haematooncological emergencies and few interesting cases. So to begin the talk, Dr. Anjana will be presenting the talk. Dr. Anjana is our DNB resident, and after each case, there will be a focused discussion by our esteemed panelist and speaker, Dr. Nalini Pati. So I'll just have a brief introduction to Dr. Nalini Pati. So sir is basically senior consultant, hemato-oncologist, and he's working in Canberra, Australia. He's a senior faculty, Australian National University and University of Canberra. He is a visiting professor, Manipal University, Manipal, India. Dual fellowship. He has got dual fellowship in Australia, FRACPA and FRCPA, and he has a previous haematooncology training person from the All India Institute of Medical Science, New Delhi, prior to moving to Australia. So we are lucky to have him here, and actually we are fortunate that he actually belongs to my place also, the state Odisha. So I welcome Dr. Nalini Pati. And we have other panelists with us, Dr. Divya. Dr. Divya is my co-colleague, Apollo Hospital, Navi Mumbai. She's working as a consultant intensivist. And with us, Dr. Saroj Patnaik. Dr. Saroj Patnaik is consultant intensivist, critical care specialist at Apollo Hospital, Bhubaneswar. And also we have our other panelist, Dr. Achilles is going to introduce Dr. Vikas. So Achilles, can you please take over and let's start the session.
So thank you very much. We have with us the two more panelists, Dr. Srikanth Samavedan. Basically, he is the head of the Department of Critical Care at Virinchi Hospital, Hyderabad. He has done a lot of pioneering work in critical care, field of critical care. He has held a lot of positions in ICCM, Hyderabad. He was the chairman, president, and secretary as well at national level and regional level. And he has immense contribution in the field of critical care. I welcome Dr. Srinivas Samavedam. He will be joining us within a short span of time, maybe 10-15 minutes. We have one more panelist, Dr. Vikas Bhagat, who is a friend of mine. So basically, Dr. Vikas is a DM in critical care from Tata Memorial Hospital, and post that he is now at Astor Group of Hospitals, Dubai. He is a critical care consultant over there, and he has immense experience in handling oncological emergencies, as being trained from Tata Memorial Hospital, which is an onco center. He has a vast experience of handling oncological emergencies. So we will a lot of insights from him also. With this introduction, I would like to welcome Dr. Nalini Pati to start the presentation, and I also request Anjana to share her slides as well. Thank you very much, sir.
Thank you, sir. Shall I start, sir?
Yeah, please.
Moving on to the presentation, my topic for today is haematooncological emergencies. So moving on to the first case, we had a 57-year-old male who was a known case of acute myeloid leukemia on chemotherapy, who completed 4 cycles, admitted with complaints of recurrent fever and throat pain since 2 days. He was shifted from the ward to the ICU in view of hypertension with a blood pressure of 90 by 60 millimeters of mercury. So on general examination from the ICU, there were no rashes, no signs of thrombophlebitis, cellulitis, or pustules. He was conscious, oriented, pallor was present. There was no icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy. He was febrile with a temperature of 102 degree Fahrenheit. Pulse rate was 116 per minute. Blood pressure was 90 by 60 millimeters of mercury. Saturation was 100% on room air. Respiratory rate was 16 per minute. Respiratory system, cardiovascular system were within normal limits. Per abdomen was soft. Vowel sounds were present. Central nervous system, there was no focal neurological deficit. So we did some lab investigations for him, and we got an HB of 8.6 with a WBC count of 800, of which neutrophils were 25% and lymphocytes were 65%. So absolute neutrophil count was 200. Renal parameters were normal. Creatinine was 0.9. Blood urea nitrogen was 30. Liver function tests were showing total bilirubin of 0.6, SGOT of 56, SGPT of 40, and alkaline phosphatase of 80. CRP was 32, PCT was 0.5. So we sent a cultures to look for any source of sepsis. Urine and blood cultures were sent. Urine routine was sent, which all of them were sterile. We didn't get any growth of microorganisms in there. We did an ABG. ABG was also normal. So we came to a conclusion of febrile neutropenia, most probably induced by the chemotherapy that he took. And we started him on IV fluids, broad spectrum antibiotics, injection meropenem, 1 gram TID, and injection Targocid 400 mg IV BV, followed by OD, injection caspofungin 50 mg IV OD, injection Grafil, colony stimulating factor, and hydrocot 50 mg 6th hourly. Since he was hypotensive, he was hydrated. Along with that, he was started on noradrenaline infusion. His chemotherapeutic drugs were temporarily withheld. So then we followed up the patient and we found to have his neutrophil count being improved. He was afebrile at the time of discharge and he was hemodynamically stable post the treatment.
So yeah, I think this is the end of the this first case, and let's hear from the hematological perspective. So basically, it's a case looks like a febrile neutropenia. So what are the management protocol? Dr. Nalini can better describe us. Then we'll hear from the intensivist perspective from the panelist. Sir, can you load your slides, sir?
Yes, I will.
Yes.
Thank you, first of all, for inviting me to participate in this webinar. Kind of, it's such a wonderful thing. And I must say one thing: we hematologists or oncologists can't survive without ICU support and ICU consultants. So we always need them, whether it is India, whether it's Dubai, whether it's Australia. So we can't live without you. And thank you so much for such lovely gesture and inviting me. So I prepared very small slide presentation, but I think going back to this case, so I think it's wonderful. I mean, way it has been managed. Just again, I don't want to touch about the antibiotic that is used upfront, which probably as per the local protocol and local isolates. So that's fine. Now, the only one question I have. Whether the caspofungin was used and whether that was continued or just kind of empirical, which was subsequently stopped. That's something probably if you know. But if it is continued, how long the caspofungin was given?
So in this case, sir, I think the caspofungin was used empirically because when there is a profound neutropenia and severe neutropenia, most of the times when the patient comes to the ICU, so the first line is empirically treatment. We used to give this antifungal meropenem and the gram-positive coverage, and subsequently, according to the culture report, we de-escalate, and then that particular antibiotic is being continued.
Yes, very true.
So as this patient was hemodynamically unstable, showing neutropenic sepsis, I think it was worth starting echinocandins with BL-BLI combination and 2 broad spectrum antibiotics on the board. Probably, I think we could control this septicemia. But but did you get any growth in the culture and any organisms identified in the culture medium? Dr. Anjana?
No, sir, cultures were sterile.
So even if the cultures are negative and we have started the antibiotics, how long we should continue the antibiotics in such circumstances? Because in neutropenic sepsis and all
So,
that.
so what
Yeah.
is the protocol in Australia? And we would like to also hear from the other intensivists.
Yes, absolutely. And just I want to share the screen. Just no, this will stop the other screen sharing. Do you want to continue? Yes. Sorry, somebody can help me. Computer audio, second camera, files. No, move to inbox. If there is, I mean, something's preventing me to share this slide. Can you stop sharing this one? Maybe I will start mine.
Okay, sir.
Yeah. Anjana, please stop sharing your slides.
Okay.
Then I'll try. I don't know what's happening. Okay, continue.
Yeah, no.
So then so anybody can guide me. I think I never had an issue with sharing before. So it bringing a box saying that Dropbox, Microsoft OneDrive, Google Drive box, then Microsoft SharePoint.
Sir, you can directly go to the share screen option.
Yeah, that's what I'm clicking. There is a green option, share screen. That brings a page, basic. Shall I say the desktop one? This is whiteboard. Share screen. 1 second. Sorry, just give me 1 second. I'm
Yes,
just
yes,
trying to fix
no
it.
problem. So by this time, can we just take the questions to other panelists by the time you share?
Yes, 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 yes,
Okay.
yes.
So what is your protocol, Dr. Vikas, in your institute as an intensivist? Because
Yeah,
most
as an
of the time,
intensivist, yeah. Hello.
yeah.
First of all, thank you for inviting me for this discussion. Uh, any febrile neutropenia, we admit in ICU in isolation, and we start on a broad spectrum beta-lactam, at least covering the pseudomonas, and MRSA coverage are added if there are added risk factor for MRSA, like repeated hospital visits, repeated admission, IV antibiotics in last 90 days. We usually don't add antifungal from day one because if the fever persists with an MRSA specific agent like vancomycin or teicoplanin along with an anti-pseudomonal agent, wide spectrum BLI, like piptaz, piperacillin, tazobactam, or carbapenem. If the fever persists for 3 to 4 days, then only we consider adding antifungal. We try to find an evidence for any fungal infection, but many a times we don't find any. So in those cases where we add antifungal, if there's an improvement after adding antifungal, we stop it from the day of the improvement, that is 14 days after the day of improvement or day of improvement in counts or fever. And we'll continue the antibiotics as long as the neutrophil counts are lesser than 1,500. That's the protocol, apart from the other supportive measures.
Okay. And most of the times, this cultures in a febrile neutropenia patient don't yield anything.
Exactly.
So still, for how many days you will continue the antibiotic even if the culture is negative, or
even if the culture is negative, for antibacterials, that is MRSA and anti-pseudomonal agents, we continue for 7 to 10 days, or at least till the neutrophil counts are in the normal range, that is above 1,500. And antifungal, if the patient is improving on antifungal, then we'll continue antifungal for 14 days from the day of improvement, from the day the patient became a febrile or improvement in the counts.
Okay, thank you. So I think sir is able to load the slides. So, sir, can you able to move your slides?
Yes, one just, yeah, almost. I think this is.
Yeah, and the antibiotic therapy should also be guided by the risk factors that the patient is having. What is the antibiogram of our hospital, and what are the risk factors? What is the class of the patient? Okay, neutropenic patient, they are already in a class 3 kind of a patient. They must have visited the hospital for chemotherapy, and they are likely to acquire nosocomial bacterial infection. So it is prudent to start broad spectrum antibiotics, considering what are the possible organisms this patient may be harboring colonization, and the antibiotic should be instituted accordingly. One more thing is, like, the antibiotic therapy should also be guided by the procalcitonin. If the procalcitonin levels are coming down by 50%, or there is reduction in procalcitonin and patient is hemodynamically stable, probably we can de-escalate the antibiotics, and probably if the procalcitonin is negative as well, we can stop the antibiotics upfront.
Yeah,
Do you agree with this, Dr. Vikas?
I think
Yes.
let's start with sir. He has already loaded the slides.
So yeah, wonderful. Thank you. So basically, there are a few slides, but I will skip it depending on the time and everything. So very important. First of all, we need to be very clear about the definition. That's actually, no matter where we work, still it comes over and again. So neutropenia meaning any neutrophil count less than 1.
Okay.
The second thing, if you don't, let's say patient comes to emergency or presents to ICU, we don't know the neutrophil count. We need to assume that patient has neutropenia if the patient has a history of any chemotherapy. So that's the first thing. Second, about the temperature, there's so many definitions, but overall worldwide, this has been seen that you can use one observation of temperature above 38.4 degree or otherwise 101 degree Fahrenheit, one reading, or sustain more than 1 hour 38 degree. But there is some issues with this kind of two definitions. Now, because you may waste 1 hour if you have to measure multiple times. So I think most of the centers, what they have done, anybody with a history of chemotherapy, even the neutrophil count is not known, presume that the patient has neutropenia. Second, one temperature of above 100.4 degree Fahrenheit or 38 degrees Celsius. So you don't need to wait for 1 hour. So that way you probably save that vital 1 hour where you can institute some measures, some interventions. And if the temperature is also low, but there is other hypodynamic, hemodynamic instability such as tachycardia or blood pressure systolic less than 90, then you should presume that patient has febrile neutropenia. Now, there are some associated risk factors where we need to be a bit more careful about possible neutropenia, and we need to jump in and do things very quickly. So for example, if the neutrophil count is very low, we know that neutrophil will be below 0.05, otherwise less than 50, or prolonged neutropenia more than 7 to 10 days. And this is a significant risk for mortality. Active patient has active malignancy, other comorbid conditions if they have. Similarly, if there are again issues like there are low risks if the neutrophil count is low for less than 10 days, or there is no other associated comorbid conditions, or the patient has cure. In those cases, probably can try manage as outpatient through oral antibiotics. But particularly, as I said before, if you have a patient who has cytopenia or very low neutrophil more than 10 days, and you know the proven source of infection like catheter infection, then you can categorize it as high risk, and then you have to institute proper interventions. IDSA guideline has pointed about two important things. One, when there is a patient who has febrile neutropenia, we sometimes forget to examine their oral cavity. Also, if possible, we don't need to do per rectal examination, but I think we need to look at perianal site, see whether there is any ulcer there or anything that is probably as a source of infection. So it's very, very important to look out for the sites where normally we sometimes miss. And your initial evaluation would lead to the risk stratification and then that will help us determine what is the best way to progress and how quickly we should do it. And the vancomycin actually is not essentially needed in most cases, unless there is a source that is known that possible gram positive infection or there is a previous history. So then, what are the investigations? Again, I don't want to waste too much of time, but I think one important thing is we need to take 2 sets of cultures. If the patient has an indwelling catheter, then it has to be one from the indwelling catheter, the other one should be from the periphery. That is very important. And always we should look out for tunnel sites, exit site, whether there is any pus discharge or is any redness, then that would probably prompt you to do for the imaging studies. But just X-ray urine culture, those are very standard. Again, nobody does routine surveillance cultures, but if there is a history which is significant in the previous episode of febrile neutropenia, even the patient is not presented, then I think the team, it's all the success is surrounding actually a hematological outcome. It remains on how much we are proactive in managing such cases. So in some cases, probably serial surveillance cases, cultures are useful, but not in all cases. So when we decide about empirical treatment, how do we decide that? So first of all, we need to see how quickly, how best we can protect against early mortality and morbidity. And the other important factor, which is very, very important, I looked at a study in our own hospital, using the antibiotics within 30 minutes, within 1 hour, within 2 hours. There is a significant difference in terms of their outcome. So the whole message is, if we can use antibiotics within the first hour of having the past febrile episode, that probably would help improve in the patient outcome. So if not, if we are aiming for 30 minutes, so within 30 to 60 minutes, the first dose of antibiotics should be given to the patient. And again, as we know, the case like what was presented, so it looks like a case of gram-negative septicemia, where you have significant hypotension. So in some cases, I think it's very important to do the investigation at the same time, make sure that the antibiotic is given as quickly as possible. And in some cases, we do use gentamicin as a bolus, the first dose. The subsequent doses would be decided based on the subsequent cultures. But at least as a start, you can use combination, combination like your piperacillin tazobactam or even meropenem that has been used in this case. But maybe aminoglycosides probably would be useful, because we know vast majority of the cases are gram-negative septicemia. Then I think as I said, what are the essential properties of the empirical regimen? So it should be broad spectrum. It should have a high serum bactericidal levels. It should be affecting the absence of the neutrophils. And it should have a low potential for emergence of resistance. And it should have a acceptable toxicity, based on which all these regimens are determined. There are many regimens. I don't want to go into detail, because it should be based on the local antibiogram. It should be based on the local isolates. I mean, that's why in any regimen can differ from hospital to hospital and country to country. But the basic stuff is, if you're deciding about aminoglycoside, probably your regimen could be different. But if you're using as a monotherapy, maybe you have to use piperacillin tazobactam or cefepime if there is a penicillin allergy, or you can use meropenem, imipenem, and other as mentioned here. Again, vancomycin should not be used in all cases unless there is a proven source of gram-positive infection in the past. Otherwise, it's not mandatory to use vancomycin. But aminoglycosides such as gentamicin, we use in cases of gram-negative septicemia just as a start dose. Then, depending on the culture positivity, we decide whether we need to continue or not based on the sensitivity. I'll just skip this one. Where you use vancomycin in the initial regimen, many studies looked at that. There is no change in morbidity if you use vancomycin upfront, but probably you can use less of amphotericin B, because we generally wait 3 to 4 days, and I think one of the doctors mentioned that we wait 7 days. I think all are correct, but probably if you think there could be a gram-positive infection, then you probably avoid using amphotericin or antifungals at that point. But there is no change in the febrile episodes. But the other issue with using vancomycin so much actually increases the VRE emergence. So that's again we need to be aware of. What is the CDC recommendation? It should not be used in the initial regimen unless the culture proven by 3rd day, and it not to be used prophylactically for central line infections unless there is a previous history. Ciprofloxacin again, it's as a monotherapy. It causes a lot of breakthrough infections. It's only reserved for MDR state infections. Otherwise, it should be avoided. We don't use ciprofloxacin, but it's a good strategy to use as a prophylaxis, but not as a treatment. Coming to antifungal, we had some discussion surrounding antifungal. So basically, we use antifungals mostly amphotericin B, and I mean that's quite broad spectrum, and in some cases caspofungin, yes. But we wait for the 5 to 7 days period. We first of all look at the CT sinuses, abdomen and pelvis, and then see whether there is any source. But mind you that patients with AML, the case that was presented, generally they will be on some form of antifungal prophylaxis such as posaconazole or voriconazole. So such cases probably continue the posaconazole. We can probably increase the dose, but again, prophylactic dose and the treatment dose pretty much similar. So continue posaconazole. Then we have 5 to 7 days time and see if the fever doesn't subside. Then by the time you will have more information, then you have the option of adding at that point after 5 to 7 days. And you can, as your front, we use amphotericin B, caspofungin, and idurlafungin in respective cases depending on the suspicion. And prophylaxis wise, patients can be on fluconazole, posaconazole, vori, or ampho-B. Some cases, just to let you know, like if there is a liver toxicity, we can't use voriconazole particularly or fluconazole. In that case, we use 3 times a week, 1 to 2 milligram per kilo of amphotericin B, which is equally efficacious. So what's the benefit? Again, there could be early clinical defervescence of the fever. It could lead to less morbidity. And then, you can probably, in suitable cases, get better result. GCSF has been used in that particular case. Again, we tend to use GCSF, the standard dose 5 microgram per kilo per day, but there is a possibility that you can increase the dose to double the dose, 10 microgram. If you haven't seen any response within 3 to 4 days, then you can double the dose to 10 microgram per kilo per day. PCV prophylaxis probably is not indicated in all types of cancers, and it's indicated mostly in acute lymphoblastic leukemia or lymphoma type of any lymphoma sort of disease, because if the steroid use is prolonged, particularly in ALL patients where the chances of PCV infection is high. So in those cases, generally it's not so much as a risk in acute myeloid leukemia kind of treatment or the conditions. But generally, as we know, the risk is more with ALL and solid tumors and post-bone marrow transplantation patients. And usually we use trimethoprim and sulfamethoxazole combination, BD dose like Bactrim DS twice a day, twice a week as a kind of standard regimen. Other drugs, if the patient is has allergy towards sulfa, then you can use pentamidine once a month nebulization. That's again preventative therapy. And then the treatment dose will be high dose. Just touch upon the granulocyte transfusion again. What is this? Basically, as we know, white cells, I mean, the neutrophils are very short lasting, and you have to give pretty much every 24 hours granulocyte infusion. It's not easy, it's pretty difficult to collect. You have to have a donor who is probably ABO compatible, and sometimes we have to still look for some HLA matching as well. So it's very difficult. We don't use it. The simple reason is that it probably would be successful if you use it, but as you know, it's very short lasting, and you have to probably continue for at least a week, and infusion to be given daily. Again, I'll just skip this one. Again, just to touch upon the IV catheter related infections. Again, I mean, if there is a proven infection, the line has to come out. Particularly the patient is hypotensive and you have started the antibiotic and patient doesn't improve within 24 hours, to try to pull out the line. But in some cases, if the child and the line is pretty crucial, then we can use other treatment modalities if see whether we can salvage the line. But in some unusual infection, fungal infections, the line has to come out. So I will stop there and happy to, I think we have other 2 cases. Thank you.
Yeah, thank you, sir. So let's hear from our other 2 panelists, Dr. Divya and Dr. Saroj Patnaik. What is their take-home message and any comment they want to put in febrile neutropenic patient from the intensivist perspective?
Yeah, it's a nice presentation. Thank you, sir. The thing about I want to highlight, like in febrile neutropenia, because of the immunity is blunted, we need to find out the non-infective cause of fever. That is one thing. Second, need to stress on the source of infection, because the site and source, unless you find whether the pneumonia or UTI or any bloodstream infection, that needs to be stressed on, because most of the time the cultures comes negative and the patient will be having multiple issues. So the site of infection to narrow down is very much important.
Thank you, Dr. Saroj. Dr. Divya, if you are there.
Yeah, hi. So I just wanted to, I wanted to agree with sir that antifungal probably we can start if there is persistent neutropenia, persistent fever after 5 to 6 days of therapy, unless there is any other suspicion for a clinical fungal infection. And the other thing I wanted to know is Grafil injection, whether we should routinely use it for every patient who comes with neutropenia, or should we use it only for patients who are more high risk or have prolonged neutropenia. For those patients, it should be reserved.
You mean the GCSA, you mean?
Yes, sir. Yes, sir.
Yeah, so I think we use in all patients, particularly patients like AML who had chemotherapy, already had 3 or 4 cycles. They will have prolonged neutropenia for at least 3 to 4 weeks. So we use standard GCSF. There are some conditions where you can use PEG filgrastim, PEG GCSF, but again, in a patient like AML, we tend to use standard GCSF, which will use daily till you see some neutrophil recovery.
Okay. Sir, there is one question from the from the chat box. What about the antiviral prophylaxis, and in which patients the CMV should be suspected, and how to work up for the CMV?
Very good question. So CMV again, there are some specific symptoms. Obviously, if the patient has some local signs or maybe diarrhea, and you have looked at all the other options and there was no other focus of fungal or bacterial infection, then obviously look out for a CMV serology and CMV PCR. So we send the CMV PCR roughly around second week if the fever hasn't subsided, and then look out for urine for CMV antigen and those things. So I think if the patient hasn't improved by the second week, we are in big trouble. Then we immediately look out for other type of infections like CMV and anything. So it's a very good question, and definitely we should be thinking about CMV.
Any other viral prophylaxis you recommend, sir?
Viral prophylaxis, we do continue valacyclovir as a routine for the patients like such the case that was presented. But they get 500 milligram once daily unless they have some specific sites of his specific infection that is proven. Then we give higher dose for 3 to 5 days, followed by maintenance again 500 milligram once daily. But that's for the prophylaxis type. But if there is proven CMV infection like transplant patients, we use valganciclovir or even ganciclovir to start with.
So another question to Dr. Srinivas from the delegates, like ticoplanin versus vancomycin and the experiences of both the drugs.
Yeah, unfortunately, all the American guidelines have mentioned vancomycin. They are not very well versed with ticoplanin. But in our population, we prefer to use ticoplanin for multiple advantages. Like most of the patients who come with septic shock and sepsis, they develop AKI, acute kidney injury, where we can give full dose of ticoplanin for first 3 days, and the dose adjustment is needed after 72 hours of ticoplanin. So when there is a neutropenia with a septic shock, we want to hit hard. I think ticoplanin is better to go for, according to our experience, because we can give the full dose, we can hit hard, and it doesn't causes kidney injury as much as vancomycin. So our choice is always ticoplanin unless we are suspecting any CNS involvement, where vancomycin remains the drug of choice.
Okay, we don't use ticoplanin that much unless there is some, but anyway, that's fine. I mean, antibiotic generally should be based on the local data and local antibiotic and those things. But the only other problem with ticoplanin is actually it can suppress your bone marrow. So if the patient has significant bone marrow aplasia, then I think one need to be a bit cautious, but again, use and see what happens. Yeah.
So by the time Dr. Anjana will load the slides, there are two more questions. One is to how to analyze the CMV DNA levels. So one question, sir, if you can answer, sir.
So again, we look at the log increase and the copy number. So I think that is very important. Let's say 1 week there is log 1 and with copy number was 500. Then next week was log 3 with the copy number 5,000 or something like that, or 50,000. So that makes a big difference. So basically, you need to look at the log as well as the copy number. Just having one positive PCR doesn't make much sense. We still monitor the numbers and see whether they are symptomatic. And many cases we get away with not having to treat those patients.
So another question
that antibiotics. Yeah, having said that, antibiotics are very important and crucial, but at the same time, infection control policies are also very important. Simple hand washing and isolation of the patient is also very, very important, because most of the times we keep on bumping with the antibiotics, but if we just forget the infection control, probably we will not be able to achieve much. So that's why it is important that policies and protocols should be followed very stringently. Hand washing and isolation of the patient is very, very important.
Absolutely, he hit the core of the whole thing. Absolutely, sir. I think it's very, very important to maintain the other important measures as well, not just antibiotics. Absolutely correct. Absolutely correct. And
Yes.
particularly if the patient we are dealing with who doesn't have a neutrophil count, doesn't have a good immunity, and has had a significant treatment, I think definitely all these measures should be strictly followed, particularly everyone. Yeah.
So another question to Dr. Vikas. So from Dr. Nishant. So basically, he wants to ask about the invasive pulmonary aspergillosis, when to suspect and how to suspect.
Uh, yeah, it's a good question. Actually, first of all the neutropenic patients are immunocompromised, so we must include aspergillosis in our DD. Most of these patients, though, especially in the case presented like AML, they are on a prophylaxis with voriconazole or posaconazole before the chemotherapy. In these cases, we should take a thorough history and physical examination, especially in cases where there is an underlying lung disease like COPD, bronchiectasis, or previous severe pneumonia. In those cases, the chances of developing invasive aspergillosis are high. And at the same time, they usually present with typical lung signs like dyspnea, increased sputum production, and many a times associated with arthalgia. If there is any sinus tenderness or nasal discharge, or there are dermatological changes related to fungal infection, those cases we will definitely work out for invasive aspergillosis and start the appropriate therapy as soon as possible.
Yeah, thank you. So I think we'll taking up the next case by Dr. Anjana.
So we had another 61-year-old gentleman who is a known case of B-cell lymphoma who was initiated on chemotherapy recently, who presented to the emergency department with multiple episodes of vomiting, muscle cramps, and one episode of seizures. The ABG taken from ER showed high anion gap metabolic acidosis with a potassium of 7 and ionized calcium of 0.7. ECG showed tall T waves with broad QRS complex. He was started on anti-hyperkalemic measures. Basic blood routine investigations were done and was shifted to ICU. So in the ICU on examination, head to foot examination was normal. He was drowsy, arousable following verbal commands. There was no pallor, icterus, cyanosis, clubbing, pedal edema. He was afebrile. Vitals, pulse rate was 110 per minute. Blood pressure was 110 by 60 millimeters of mercury. Saturation was 100% on room air. Respiratory rate was 16 per minute. He was maintaining a urine output of 60 ml per hour in the last 2-3 hours. On systemic examination, respiratory system and cardiovascular system were within normal limits. Per abdomen was soft, bowel sounds were present. Central nervous system, GCS was 14 by 15. Pupils were bilateral equivalent, reacting. The lab investigations, the basic blood test came by that time. So it showed an HB of 9, WBC of 4,282 with neutrophils 48% and lymphocytes of 46%. Renal function test showed a creatinine of 2.6, blood urea nitrogen of 68, sodium of 145, and potassium of 6.8. Liver function tests were normal. So he was started on initial anti-hyperkalemic measures, and we further evaluated him for the other electrolytes. And serum calcium came out to be 5 with an albumin level of 1.8. The corrected calcium was below normal. Serum uric acid was 8 and serum phosphate was 7. So we came to a diagnosis of tumor lysis syndrome. So we started him on IV fluids, anti-hyperkalemic measures like calcium gluconate and 25% dextrose with insulin were continued. He was started on allopurinol tablet orally and urine output was monitored. But in the next 12 hours, the patient started becoming hypoxic, requiring about 4 liters oxygen to maintain a saturation of 96%. He was tachypnic with a respiratory rate of 32 per minute. Urine output started dropping to 10 to 20 ml per hour in the last 2-3 hours. ABG and renal parameters were repeated. Serum creatinine now was 4.8 with a blood urea nitrogen of 87. Sodium was 142, potassium was 7.5. Serum uric acid jumped to 9 and serum phosphates was still at 7. ABG was repeated, which showed a pH of 7.23, bicarb of 8, PCO2 of 42, potassium of 7, and ionized calcium of 0.8. Nephrology reference was taken in view of persistent high uric acid and phosphate levels and potassium levels, and he was started on dialysis. So during the dialysis, he had a sudden asystole. As ACLS protocol was initiated, he could not be revived, and he succumbed to the illness and expired.
Yeah, so it's basically the one of the patient that I think she lost. But in view of the sudden emergency of tumor lysis syndrome, sir, by the time you load your slides, I'm just passing the questions to Dr. Saroj. So, what could be your take as an intensivist in such situations where the patient had suddenly developed tumor lysis syndrome in your ICUs?
Yeah. Here the anticipation is the major key factor, because the tumor lysis mostly starts around 3 days before and around 5 to 7 days after any chemotherapeutic agent. So we need to keep it in mind. The patient, when any patient deteriorating after chemotherapy, during that, then need to do an ABG and find out the calcium, phosphorus, uric acid level, potassium. All these are because there is these are the very important for lab diagnosis of tumor lysis syndrome, and prompt treatment will definitely can save a lot of patients. So need to be a bit very cautious about this thing. That is very important.
Yeah. Tumor lysis syndrome is one of the oncological emergencies, which is very crucial. If the treatment is not instituted in time, we can lose patients, especially due to hyperkalemia and electrolyte disturbances, the commonest cause of morbidity and mortality. So in such situation, aggressive correction of potassium is very, very important. And the dialysis may be very important in this situation, because no matter you try to correct hyperkalemia with calcium gluconate or GI drip, it will all try to push the potassium intracellularly, and later on it is going to come back in the serum, and again there will be persistence of hyperkalemia. So a definitive treatment in the form of immediate institution of dialysis and continuous renal replacement therapy for that matter would be very much important, and continuous correction of potassium, repeat every hourly ABG, and close monitoring of the potassium, and the ECG monitoring also is very, very important in this situation.
Yes, sir.
There are yeah. And there are, I think Dr. Nalini Pati is going to highlight on this issue, but these are some take homes from my side.
No, excellent. Thank you. Now, I think wonderful, wonderful case that brings several questions, and then that everyone we face, and in hematology, always I tell my juniors something like that. A lot of things you have to predict, a lot of things you have to anticipate and act upon before things happen, because when things start to show up, then probably we don't have much time, and the patient, they don't give much time. So I mean, it's a good case. So I will just go through my slide presentation. Everybody can see the slides properly?
Yes, sir.
Okay. So as we all know, there's a life-threatening oncological or hematological emergency. It can occur spontaneously. That's another important thing we need to know. Tumor lysis syndrome, not necessarily always after the chemo or radiation. It can happen spontaneously. And as we know, it's caused by death or lysis of a large number of cancer cells. And we'll go through which are the cancers will have a high chance of tumor lysis. This results in the release in the intracellular ions, nucleic acids, proteins, and their metabolites into systemic circulation. What is the end result? So a lot of metabolic abnormalities such as hyperuricemia, hyperkalemia, as you have seen in this case, hyperphosphatemia, and that leads to secondary hypocalcemia and uremia, which can lead to renal failure, cardiac arrhythmias, which happen in this case, seizures, neurological complications, and potentially sudden death, which can happen. And usually is more common on the first cycle of treatment. That's why in some chemotherapy regimens, we give what is called pre-phase therapy. We prepare those patients before you give the actual chemotherapy. Again, it's not up to the ICU consultants to decide, but it's up to the hematology oncologist team to decide whether patient may have a hemolysis syndrome, maybe we should give the patient is what is called pre-chemotherapy. So we prime the patient so that their body will be ready and they won't have significant hemolysis when they are given full load of chemotherapy. And early recognition of the at-risk patients is really very crucial, and which will lead to early institution of different therapy, and which will probably lead to greater success. Now it can be classified into two. One is the lab TLS, laboratory hemolysis syndrome, or clinical TLS. So lab evidence of the metabolic changes associated with TLS without the symptoms, patient is completely asymptomatic. But clinical TLS, again, patients should have the lab TLS plus one or more specific abnormal findings in the lab, as well as those they have developed life-threatening symptoms such as cardiac arrhythmia. I'll just take you through, it's a Cairo base of definition of, so basically the pretty standardized definition. So presence of two or more of the metabolic abnormalities at presentation, or there is a change in 25% from the baseline within the 3 days prior to or 7 days after commencement of therapy. What are those? Sorry, some of those actually markers probably not and different measures, so hopefully that makes still some sense. Uric acid greater than more than 0.476, or there is 25% rise from the baseline. Potassium, again, any more than 6 or 25% increase from the baseline is very, very important. Phosphate, similarly, more than 1.45 millimole per liter or 25% rise. Corrected calcium is less, so below 1.75 or 25% less from the baseline. Which any of those, two of those will classify as to lab TLS. The presence of so clinical hemolysis syndrome, what is that? So presence of the lab TLS, as I mentioned in the previous slide, plus one or more of the following clinical complications, which should not be directly linked to the chemotherapy that patient received. What are those? Again, renal insufficiency defined by increase in serum creatinine greater than 1.5 times the upper limit of normal. So it doesn't matter whatever the norms you use, it should be more than 1.5 times. Again, it's all institution, age, and gender defined. Cardiac arrhythmia or sudden death, and seizures. So if the patient has any of these, one of these, plus the lab TLS, then classifies and the definition of clinical TLS. Again, there is a grading. Again, I don't want to bore you down with all that, but again, grade 0, for example, the creatinine within normal limits up to 1.5, there is no cardiac arrhythmia, there is no seizure. So if grade 1, if the patient has serum creatinine up to 1.5 or above 1.5 times the upper limit of normal, or there is no intervention that is required for the cardiac arrhythmia and there is no seizure. So by the time we reach grade 2, we are pretty much heading towards the critical side of the hemolysis syndrome. We should avoid reaching grade 2, which has some of those neurological manifestations. It has cardiac manifestation, but still there is manageable. Still patient can be manageable. But if it goes beyond grade 2, that means the patient's creatinine is almost 3 to 6 times the normal, and patient is symptomatically or incompletely controlled medically and controlled with the device. So then again, we are heading towards the bad territory. So coming to the clinical manifestations, although symptoms may occur before the commencement of cytotoxic therapy, because there could be spontaneous hemolysis syndrome. They're observed mostly within 12 to 72 hours after the initiation of the cytotoxic treatment. And I think sometimes we have to predict and start the allopurinol or even rasburicase. We'll talk about those even beforehand. I mean, some high-risk patient we give before we give the chemotherapy, because as I highlighted many times already, I have highlighted, basically the patient may have spontaneous hemolysis. What are the symptoms? Nausea, vomiting, diarrhea, anorexia, lethargy, edema, fluid overload, congestive heart failure, hematuria, cardiac dysrhythmia, seizure activity, muscle cramps, tetany, syncope. So, I mean, they are all non-specific symptoms, but again, if the patient didn't have such symptoms, but has developed, then I think we should suspect about, even though it's non-specific symptom, but I think we should develop the suspicion for that patient may have developed hemolysis. So which are the risk factors, which is very, very important. Next two or three slide, I think particularly for the junior doctors or students, I think very, very important. Those tumors, they have a high tumor cell proliferation rate. Bulky disease, any mass more than 10 centimeters, for example, a Burkitt's lymphoma is actually high risk. Even follicular cell lymphoma, even chronic lymphocytic leukemia, if there is a large bulky lymphadenopathy. The white cell count, if it is more than 25 or 25 times 10 to the 9 per liter, there is an increased LDH more than 2 times upper limit of normal. And sometimes also it has been seen that if the malignancy is highly sensitive to the chemotherapy drug, that patient may develop tumor because the tumor is going to shrink very, very quickly. And sometimes when you use potent chemotherapy, for example, in transplants, you use quite intense chemotherapy. In those cases, there is a high chance the patient may develop tumor. And these days, when you use a lot of novel and targeted therapy in conjunction with normal cytotoxic therapy, then there could be augmented hemolysis. But for example, the drug that has been used over the last 1 or 2 years called venetoclax in CLL, it leads to significant risk of hemolysis. So we have to develop this kind of suspicion that the patient may develop before that actually happens. And which are the tumors? Just to name, there could be more, but most importantly, Burkitt's lymphoma heading the list, leukemias, particularly if there is a high white cell count, acute lymphoblastic leukemia, lymphoblastic lymphomas, diffuse large B-cell lymphomas, and solid tumors with high proliferation rate, which could be very sensitive to the chemotherapy. So if patient has any of those diagnoses, then we have to be more alert. And what are the other additional conditions where that may predispose to developing TLS? If the patient has concurrent renal insufficiency or renal failure, patient is dehydrated, there is a decreased urinary flow due to whatever the cause, there is a pre-existing uremia or hyperuricemia, then I think the patient will have significant risk of TLS. And even the patient has pre-existing hyperphosphatemia. So again, there is a way to stratify such patients as to saying high risk, intermediate risk, and low risk. I will focus on a few of the important points for all of us to remember at least. If the patient has Burkitt's lymphoma, no matter what is the size of the lymph node, where the mass is, but they are categorized as high risk for hemolysis. Similarly, ALL patient with white cell count of more than 100 or LDH more than 2 times upper limit of normal. AML with the white cell count again more than 100. So any leukemia more than white cell count of more than 100 actually classified as high risk. Advanced bulky aggressive non-Hodgkin lymphoma, the T cell lymphomas, because there will be possibility that patient may have mediastinal involvement that has high risk of hemolysis. CLL, particularly as I gave the example of using venetoclax in CLL, they have a high risk of developing hemolysis. Intermediate risk again could be in between ALL with white cell count between less than 100 and LDH of less than 2 times upper limit of normal. AML with white cell count between 25 to 100, and CLL treated with other drugs, not venetoclax, would be classified as intermediate risk. Low risk probably would be rest of the conditions. I don't want to waste your time, but again, any indolent lymphomas, myelomas, chronic myeloid leukemia again classified as low risk of developing hemolysis. Even though they have a high white cell count, they are not high risk of developing hemolysis. ALL with the white cell count less than 50, and similarly AML patient with less than white cell count less than 25. Then there is the algorithm again, looks very complex, but it is actually very simple. And how do we stratify? Basically, I mean, let's say we have stratified as high risk, intermediate risk, and low risk. How do we manage? Again, most cases, both high risk and intermediate risk patients are managed pretty much similarly, except one thing. In the high risk patients, usually it is seen and to start the therapy at least 48 hours prior to starting the cytotoxic therapy. Whereas in intermediate risk, you start within 24 to 48 hours prior to starting the cytotoxic therapy. So it is so crucial, even there's a difference between 24 hours. So I think in such cases where we suspect this patient may develop hemolysis, we need to institute those preventative strategies that patient will not go through the hemolysis complication. But for the other management would be pretty similar. I'll touch upon a bit more in detail. Vigorous intravenous hydration, plus you have to use allopurinol with the standard dose, and some cases you have to use rasburicase. If the patient is low risk, just you have to monitor and see that patient is not developing in future. So coming to hydration, which is very, very important, unless there is any contraindication, please put those patients there on chemotherapy, at least for the first cycle of chemotherapy, with a fluid of around 3 liters per meter square per day of normal. I mean, you have to use combination of saline, but try not to add any extra electrolytes into those fluids. Continue for several days to maintain a urine flow up to around 100 mL per hour, per meter square per hour. And the patient should be weighed twice daily just to see whether they're accumulating a lot of fluids, and maintain a fluid balance chart. Diuretics you can use, but it should not be required in normal patient where there is normal preserved renal function and cardiac function. You don't have to use it. And generally it is contraindicated in patients who are hypovolemic, as we know, and those they have obstructive uropathy. So try not to use diuretics on those patients. And potassium, calcium, and phosphate should not be initially added to the hydration fluid, as I mentioned, to avoid the exacerbation of the hyperkalemia. Obviously, it can lead to hyperphosphatemia, and calcium phosphate may be precipitated. So again, so try to avoid adding any of those electrolytes to the fluid. And people talk about urinary alkalinization. Again, it's not that beneficial. It's not routinely recommended. And the only available, I mean, there are a few experimental studies, and they have suggested that if you use saline alone, is as good as using alkalizing actually your urine. But there are some specific protocols we use. For example, if you're using high dose methotrexate, where you use 5 grams, 8 grams per meter square of methotrexate, there I think there is an important need to alkalinize your urine, but otherwise it's not required. It should be avoided in routine patients, particularly if the patient has developed TLS, especially when you're using aspiricase, as alkalinization has the potential disadvantage of promoting calcium phosphate deposition in the patient who developed marked hyperphosphatemia. So that is very risky. So probably for all practical purposes, unless the patient has specific need, such as high dose methotrexate, try not to use alkalizing the urine. IV sodium bicarbonate should only be administered to the patient with metabolic acidosis, otherwise not. Coming to allopurinol, again, a dose roughly 300 milligram per meter square per day. Otherwise, you can use 100 milligram per meter square orally every 8 hours. Maximum dose you can use 800 milligram per day. And in routine practice, we use a standard 300 milligram per day once given dose. However, switching to aspiricase may be necessary in the presence of deteriorating biochemical and clinical markers. But generally, as I said before, depending on the risk stratification, try to start the treatment 24 to 48 hours prior to giving the chemotherapy. And the dose may need to be reduced by 50% if the patient has pre-setting renal failure, and also patient who require prophylactic hydration would need for careful monitoring because there could be other complications. And if the patient, the dose may need to be adjusted, particularly if there is any other drug that might be interacting the drug pathway, metabolism pathway. Coming to aspiricase, it should be considered on most patients where there is a high risk of developing TLS, patients particularly with renal failure and who are unable to tolerate the high fluid inputs, where I think the aspiricase remains an important choice. Patients, they have already developed a pre-existing TLS, both clinical or lab, prior to starting cytotoxic therapy. In those cases, aspiricase has to be used before giving the chemotherapy. And particularly another simple thing, if the patient is allergic to allopurinol, again, you have to use aspiricase. And who do not adequately respond to the standard TLS preventative measures such as hydration and allopurinol. So in those cases, I think there are 4 indications where you use aspiricase. The dose, again, very standard. If it is adult, we use standard 6 milligram single intravenous dose. It's a quick infusion. Or if you are looking at per kilo body weight in children, so 0.2 milligram per kilo, you can use once daily for 5 to 7 days. But it should be given 24 to 48 hours before, or even you can give immediately after. But one important thing, and while giving the administration, it's not compatible with the glucose, so it has to be diluted in normal saline and given over 30 minutes infusion. And if the patient is getting chemotherapy, try not to use in the same line, try to use a different line, But if you are using the same line, please flush with saline, because some of the chemotherapy is given with the glucose. So try to avoid that. Use a different line if possible. If not, flush it properly with a normal saline before giving respiratory. So I will stop there. Any questions? I'm happy to answer them before we go to the next case.
Yeah, thank you, sir. In addition to all this release of the electrolytes, I think one of the most important component of tumor lysis syndrome is release of lot of cytokines. And in the ICU, when the patient comes with a cytokine storm, so that is one of the most dangerous condition. So I would like to hear from Dr. Srinivas. So how to combat the such cytokine storm because of the tumor lysis syndrome? What is his experience? Or Dr. Divya, if you can answer.
I think the most important thing is to do more frequent monitoring of all the electrolytes and the serum creatinine. Early institution of dialysis in this case, because it will help in both the correction of the electrolytes as well as the cytokines as well, and also to prognosticate to the family, because the incidence of sudden arrhythmias, as we saw in this patient.
So do you routinely use the cytokine absorbent filters, or like other modalities like your filters which are available like cytosorb filters? So do you have means evidence for that, or what is your protocol on that in such patient who comes with renal failure, with acute kidney injury, increased creatinine, with cytokine storm?
So there is no guideline for you routinely using any cytosorb filters in these cases. But I think that you can individualize according to the patient. But there is no guideline that says that early institution of cytosorb filters. Dialysis routinely helps.
Okay. So what about Dr. Vikas? What is your experience about tumor lysis syndrome in your ICUs? Sir, actually, a question is like TLS and cytokine storms are not related. Sir,
Yeah.
what is your opinion on that?
Cytokine release syndrome are like tumor lysis syndrome, but they're quite a distinct entity. These happen actually with the immune therapy, especially if we are using monoclonal antibodies, or we are using CAR T cells, that is chimeric antigen receptor T cell therapy. Usually seen in the hematological malignancies, and its management is slightly different from tumor lysis syndrome. It's not because of the hyperuricemia or the intercellular content getting released into the circulation. Rather, it is because of the immune contents and cytokines from the response from this immunotherapy.
I agree completely. I think there are two different entities, and management is also different. And people are more talking about cytokine storm and everything, particularly in the setting of CAR T cell therapy and other targeted therapy. But I think it should not be, when we all need to know that it's totally different conditions. The tumor lysis syndrome, the pathways are different, and I think, and the management also obviously varies. And we need to differentiate between the both. That is also very crucial.
Okay, thank you, sir. So any other questions from the delegate, or should we proceed to the third case? So one comment in the chat box is like CAR cell therapy. So basically, the CAR cell therapy can lead to cytokine storm. So can you highlight on this, sir?
And that's one of the most common side effect or complication after CAR T cell therapy. And again, as you know how the CAR T cell works, and that's how basically, you collect the T cells, then genetically engineer them, and then reintroduce, and they are the ones act against the tumor cells. So basically, I think the way it works, obviously, it releases a lot of cytokines, the killing of vast, rapid killing of those tumor cells. That's how it does, and that's again, we need to be aware about the symptoms like seizure activity, change in the sensorium, and other things. There could be electrolyte imbalance, but again, vast majority of those patients will have CNS manifestations. So that's again very specific to the CAR T cell therapy, and we need to manage differently. And most patients they get some of the therapies to prevent the cytokine storm.
Okay, so Dr. Anjana, can we move to the third case and the last case?
Okay.
Probably. So you need to share your slides.
So the third case is, we had a 72-year-old gentleman with a history of diabetes hypertension who was admitted with complaints of fever, altered sensorium, generalized weakness, and reduced food intake since 4 days. On arrival to the emergency department, his GCS was 12/15. Routine blood investigations were sent, and urine and blood cultures were sent from the emergency department. CT brain was done to look for any acute infarct bleed, so that was also normal. And he was shifted to the ICU for further evaluation. So on arrival to the ICU, he had a GCS of E3, V4, M5. Pallor was present. Multiple enlarged cervical lymph nodes were present. There was no icterus, cyanosis, clubbing, or pedal edema. He had a pulse rate of 96 per minute, blood pressure of 130/80 millimeters of mercury, saturation of 100% on room air, respiratory rate of 16 per minute. Respiratory system and cardiovascular system were within normal limits. Per abdomen was soft. Central nervous system GCS was 12/15. Pupils were equal and reacting. So his lab investigations showed an HB of 8, WBC count of 15,000, with a neutrophil count of 38% and lymphocytes of 68%. Renal function test showed a creatinine of 3.1, blood urea nitrogen of 45. Liver function tests were normal. Chest X-ray was normal. ECG showed short PR interval. ABG showed a normal anion gap metabolic acidosis and an ionized calcium of 1.6. So our initial differential diagnosis were meningitis, urosepsis, and possible other source of sepsis with a background of probable tuberculosis or a hematological malignancy. So we were planning for lumbar puncture, but by that time we had sent the other routine electrolytes, of which we got a calcium of 11 milligrams per deciliter with an albumin of 3.2. So corrected calcium was higher than the normal range. We evaluated him with further parathyroid and vitamin D levels, which were normal. We had sent a quantiferon TB gold since he had multiple cervical lymph nodes and we wanted to rule out tuberculosis. A general surgery advice was given, reference was given for a lymph node biopsy, and we sent an AFB, gene expert, and histopathology of the same. So in the meantime, we started him on antibiotics. We started him on hydration in view of elevated calcium levels. In the next 24 hours, his GCS dropped to 8/15. He was hypoxic, requiring about 6 liters O2. We intubated him and he was put on mechanical ventilator. Serum creatinine was repeated, which was 5, and calcium levels were still 11 with an albumin level of 3.2. So he was started on zoledronate injection and injection hydrocod 100 mg TID, taking into consideration a possible granulomatous inflammation. His urine output started dropping to 30 ml per hour in the last few hours. And after 48 hours, we got the culture report of E. coli, but blood culture was sterile. But he was already sensitive to the antibiotic meropenem, which was started. Urine output gradually dropped to 10 ml per hour. ABG showed high anion gap metabolic acidosis. Serum creatinine level rose to 7. Serum calcium became 12. A nephrology reference was taken and he was started on dialysis. Lymph node biopsy report came negative for gene expert AFP, and histopathology came out to be suggestive of B-cell lymphoma. So an oncology reference was taken and he was started on chemotherapy. In the meantime, alternate sessions of dialysis were given. Calcium levels came down to the normal value, and serum creatinine level and urine output also improved. So in view of difficult weaning, he was tracheostomized later. Due to financial constraints, relatives wanted to take him to another hospital and he was shifted to the hospital of their choice. So here we came to a diagnosis of hyperkalemia secondary to hematological malignancy.
Hypercalcemia.
Hypercalcemia secondary to hematological malignancy.
So most of the times in the ICU admissions, we will get a lot of patients who initially presented with hypercalcemia and subsequently diagnosed to have some kind of lymph node malignancy or lymphoma or any other issues. So the primary home take-home message for the intensivists is to how to control the hypercalcemia and what are the step of approaches for such patient.
Yes, I mean it's a very common one of the another hematological emergency, hypercalcemia of malignancy. I think again this case illustrates quite nicely how the patient manifests and what happened, and I think rightly the interventions were instituted where the patient had a good outcome. So again, hypercalcium of malignancy is otherwise hypercalcemia is a serious complication, and again can happen spontaneously or after starting some treatment, and again you can classify as to based on the calcium level. So it could be mild, moderate, severe depending on the calcium level. Very simple. So as per the milligram per deciliter range, 10.4 to 11.6 mild hypercalcemia, moderate between 12 to 14, and severe more than 14. And therapy should be initiated for the symptomatic patient and those who have serum calcium concentration of more than 12. I mean, in this case, it was 11, but I think maybe there are other parameter patient who are symptomatic. So in that case, rightly, we need to start the treatment then and there. Severe hypercalcemia is considered to be a medical emergency and must be treated aggressively. I think the quickly we treat, the better. Otherwise, it leads to multiple number of other complications. And what is again highlighted in many studies that 20 to 30% of malignancies may have hypercalcemia at the presentation. And there are some specific cancers which presents with hypercalcemia, particularly breast cancer, renal cancer, multiple myeloma, lymphoma, and squamous cell carcinomas. So they have high calcium at presentation. So how do we manage? Tend to give just one question I can ask later. In this case, how much fluid was given in that case, in that patient? But anyway, we can talk about that later on the case. But generally, we try to give a bit more fluid, even 4 to 6 liters over 24 hours in some cases. Has to be normal saline in most cases. And there are a few practice points I would like to pinpoint here. One is to monitor the fluid overload if the patient already has renal impairment or patient is elderly, which is very, very important because you're giving a lot of fluids. Loop diuretics rarely used and only if the fluid overload develops, not effective for reducing serum calcium. But you may use loop diuretics. And if the loop diuretics are used, other electrolytes such as potassium and phosphate needs to be monitored and replaced if there is a need. And monitor the serum calcium response. As we know that the nadir can reach around 4 to 6 hours, 4 to 6 days time. It takes some time. It doesn't happen quickly. Even if you start the therapy, it takes 2 to 4 days before you actually see the result. And you may need to consider dialysis if the patient has already developed renal failure. Just then a few points on bisphosphonates. There are a few practice points. One is bisphosphonates can cause nephrotoxicity. So adequate hydration is extremely important. It can enhance renal protection. So if you're using bisphosphonates, it doesn't matter which one, but you need to consider using proper hydration in those patients. In patients with renal impairment, it may be contraindicated, hence we need to adjust the dose. There is a clear guideline how much dose need to be reduced in those patients. And monitor serum calcium response, which I mentioned earlier. It takes up to 2 to 4 days. So try not to give the second dose of bisphosphonate until at least 4 days after the previous dose. It can cause hypocalcemia, particularly if the patient has suppressed parathyroid hormone or has vitamin D deficiency. Then we might have to replace those appropriately. And also sometimes the patient has hypocalcemia following the bisphosphonate therapy, we might have to give calcium. So with counterproductive, but we have to do it. So there are a few points I would like to highlight. A few things about what are the other treatment modalities. So denosumab, calcitonin, and steroids. So denosumab, as we know, is a rankle monoclonal antibody which inhibits the osteoclast activation and the function. Hence, the hypercalcemia resolves. Where you have to use, where you can use, for those patients they are refractory to zoledronic acid or in whom the bisphosphonates are contraindicated due to severe renal impairment, you can use denosumab. But when you use denosumab, regular monitoring of calcium is very important, as patient may develop significant severe hypocalcemia, which is high. There is a high incidence of that, particularly in patient with reduced renal functions. So I think we have used, but in very small number of cases where patients were refractory to both the pymidronate or zoledronic acid, then you can use it, but you have to really monitor calcium levels almost daily subsequently for at least 3 to 4 days. Then comes your calcitonin. It blocks the osteoclast activity, and also it also renal tubular reabsorption of the calcium, that also being blocked by using calcitonin. Its effect is very rapid. It happens within few hours of first administration. But the problem with calcitonin is actually it has a very transient effect, and a patient can develop tolerance within days of use. So again, you can't use over and over again, but it is quite effective, particularly when it is used in refractory cases. Most beneficial in symptomatic patient with severe hypercalcemia, if the calcium level is more than 14 milligram per deciliter, and when combined with hydration and bisphosphonates, so it's more effective. And so basically in refractory cases, using calcitonin and hydration probably leads to a rapid reduction in the serum calcium concentration. Another easy treatment is steroid. As we know, if you have used zoledronic acid effectively and with IV hydration and steroids, and in most cases we use dexamethasone, which is probably more effective. I can use hydrocortisone as well, but I think we use dexamethasone, and that is very effective in managing the hypercalcemia of malignancy. So that's all I have to say. Unless any questions, I'm happy to answer. But regarding the case where probably I missed it, how much hydration that was given to the patient at that point when the patient developed renal failure. Sorry, Dr. Anjana.
Initially, he was hydrated at a rate of 150 ml per hour.
150, okay, right. That's quite a bit of, and then how long the hydration was continued?
Hydration, sir, was continued till his creatinine levels jumped up and urine started dropping. By that time, he was in fluid overload, so we reduced the fluids.
Okay.
So probably these are the patients where we may have to optimize hydration, maybe to the tune of 500 ml or 1 liter per hour or something like that. Unless there is contraindication like cardiac dysfunction or low ejection fraction, or patient has compromised lung functions or already pulmonary edema or fluid overload. I think aggressive hydration is very, very important. It's a key for management of any kind of tumor lysis syndrome, or for that matter, hypercalcemia also. And the titration of the therapy should be guided by the urine output. How much is the urine output? How much is the intake given? And similarly, if exactly equal amount of urine output is maintained, that is the strategy as far as the hydration is concerned in these cases, probably, I feel so.
Yeah. So another way to approach is to mild, moderate, and severe hypercalcemia. So, so my question to Dr. Vikas: so if such patients come with a calcium level of say 9 to 10, or 10 to 12, or more than 12, so in which scenarios, how do you approach such patients? Like mild elevation in the calcium compared to the severe hypercalcemia. where there is a chances of cardiac dysarrhythmias and sudden ventricular fibrillation and your bradycardic arrest.
Yeah. In severe hypercalcemia, what we do is we give a fluid bolus of 1 to 1.5 to 2 liters, followed by very aggressive hydration like 250 to 500 ml per hour of normal saline. Normal saline is the indicated fluid. At the same time, calcitriol is used here because of its prompt action, very rapid action, though we have a tachyphylaxis, as Dr. Nalini said, but for yes, immediate management, calcitonin is the drug of choice here, because whatever we give apart from hydration, the bisphosphonates will take 2 to 3 days time to show its peak effect. So we'll start with bisphosphonate and hydration all together, but calcitriol is the drug. Steroids can be given, but steroids are usually needed in hematological malignancies where calcitriol production or vitamin D analog production, high production of vitamin D analog is the pathophysiology behind the hypercalcemia, like multiple myeloma. So again, its use is in emergency condition is not, we are not very sure about if we do not have a diagnosis of the underlying carcinoma or underlying cause of hypercalcemia. But definitely bisphosphonate, aggressive hydration, and calcitriol for very severe hyperkalemia where there are imminent risk of arrhythmias and other fatalities and morbidities. In moderate to mild, we'll definitely start with hydration. Hydration is the key. Maybe the patient may not need the loading with IV fluid or the fluid bolus, which we give in severe hypercalcemia. But apart from that, if there is no arrhythmia and there's no indication for use of calcitonin, then we can start with bisphosphonate, hydration, and steroids.
Thank you. So one question in the chat box to Dr. Saroj. Some centers, they start hydration and diuretics both together along with other treatment for high calcium level. So is it a right strategy or how to go about it? So
yeah,
Dr. Saurabh.
Oh, sorry.
So Dr. Saroj or Dr. Srinivas?
So probably if the urine output is adequate, the diuretics may not be required actually. So if the kidneys are functioning, it will automatically pass good urine output. It's only in the compromised kidney function, probably diuretics have a good role. If the kidneys are compromised, probably the diuretics also may not help, and the dialysis will be the only option that will be better off. But there are centers which continue hydration at the same time they use diuretics, and they use flushing kind of a strategy to take care of the hypercalcemia and tumor lysis. Do you agree, all of you all, on this statement?
Yeah, just one point to add. Usually the hypercalcemic patients are hypovolemic because hypercalcemia causes nephrogenic
A lot of
diabetes and
dehydration.
fluid loss is too much. So if there is no sign of overvolemia, hypervolemia, fluid overload, and the renal and the cardiac functions are okay, there's no need of diuretics in the initial stage. Yes, after initial resuscitation or hydration for 2 to 3 days, if the calcium level comes down and the patient is not diuresing well and the patient's weight is gaining and he's on fluid overload, we can give diuretic. But definitely in the initial stage of management, we should avoid diuretic.
Because that could be counterproductive. You are trying to
Yes,
overhydrate,
exactly.
and then you're giving diuretics. I think, yeah, exactly. I agree with you. So try not to use it for the first 2 to 3 days. So
yeah. And how do you monitor the fall in the calcium levels, sir? Like sodium level, is there any target, or per day, do you want to achieve any target of the calcium? Do you monitor 12 hourly or 8 hourly, or what is your strategy, sir?
So I think as long as there is a trend towards drop, we are happy to wait, because as we know, it takes roughly 1 or 2 days. Unless there is a rise, then that's problem. I mean, calcitonin probably would be helpful. But if just we look at the trend, there is no such, like you look at the number, like not like sodium, you give sodium kind of thing. So we see the trend and then we wait unless there is some medical clinical.
Serial monitoring of the ionized calcium would be quite prudent here. And then when we are monitoring calcium, we also should take into account how much is the albumin. Corrected calcium level is also very important. At times, we will have elevated serum calcium levels, but the albumin is low. And if you try to correct it, the corrected calcium is actually low. And we end up giving a lot of fluids unnecessarily and can cause fluid overload. So I think the calcium monitoring, ionized calcium and albumin levels also should be monitored together.
Yeah.
Yes, it's a
Yeah.
good point. And for all the junior doctor, I mean, it's extremely important just look at the corrected calcium. So there is no, we don't look at the calcium, hardly we look at. So we look at, because the computer may be able to give you the corrected calcium, taking into account the albumin level. If not, if you calculate and then find out, and then you just look at the corrected calcium, never look at the calcium.
So I think there is a very good formula, like the corrected calcium is the present calcium plus 0.8 into I think the 4 minus the albumin level. So if I'm not wrong. So normally if the albumin level goes down, your corrected calcium level goes up. So that is why you have to always monitor with the corrected calcium level.
We have become very lazy because we get a number from the computer. So we just look at the corrected calcium, sorry. But you're doing hard work. So yeah, good.
Absolutely.
And my question to Dr. Nalini, I mean, what about how do you manage leukemite reactions, and what is your take on this? You know, these are some of the rare cases. We find that the WBC counts have jumped up to lakhs, probably, you know, and then it becomes really difficult as to how to manage. Sometimes it may be overreaction of the colony forming units that we use, and there will be sudden surge in WBC counts, and that will also lead to a lot of infiltration in the lungs, and you will see the lungs which were absolutely all right, and suddenly it has started deteriorating, and you may have a picture like ARDS, and patient is going on ventilator or something like that. How do we take care of such
Yeah, so
situations?
such cases when you are saying the counts have gone to that high level that it has started affecting the lungs and maybe brain, and in those cases we do leukophoresis. That is the extreme form of leukemia reaction where you have to do leukophoresis, and one sitting probably would be enough. Second, probably strategy, if leukophoresis is not possible, then steroid probably is another approach. And the third, probably sometime you have to use some chemotherapy drugs if that has caused some organ dysfunction. Depending on the what type of cancer, like for example, is it myeloid, then hydroxyurea probably useful just as a cytoreductive therapy. If it is lymphoid malignancy, then probably using a small dose of cyclophosphamide will be useful, along with some steroid. So there are the three different ways, but we're talking about extreme form of leukemia reaction. Otherwise, if it is the white cell count is 30 or 40, we wait and manage the underlying condition, the counts will drop. But in extreme forms, probably leukophoresis, in some steroids and some form of mild chemotherapy would be useful, or hydroxyurea in myeloid malignancies.
Yeah. So we are not getting any further questions in the chat box, and probably we have discussed extensively all the aspect of majority of aspect of this oncohematology, and I really appreciate all the panelists and really appreciate their interactive sessions with us, and thanks all of them. So if there is no more questions, I would like to wind up such a lovely sessions, and definitely like to be invite you further for such academic sessions every week. The next week we are coming up with post cardiac arrest algorithms and prognostications by one of our eminent speakers, and I invite all of you to this session also. So Dr. Achilles, can we wind up if everything
Yes.
is you from your
Yes, surely. Thank you very much, Dr. Gunadhar, for this opportunity. And I wholeheartedly thank Dr. Nalini Pati, Dr. Vikas Bhagat, and my own colleague, Dr. Divya Kukian, for their contribution to this program. This program has been a great success for all of us, and the students have also appreciated. This is our eighth program. And I think overwhelming response was in the form of interactions. Okay, the people have contributed in terms of asking questions also, and we have been getting a lot of feedbacks as to the success of this program. Nevertheless, I would like to thank you, Dr. Nalinipati, for your wonderful insights, and hope to hear from you again and again. It was, I mean, this is one of the very important topic which is unread and not discussed as well. Only the medical oncologist or the oncological centers you will have such discussion, but it's very important for us an intensivist as well to have such discussions. And thank you wholeheartedly from on behalf of my team. Apollo team. I really appreciated your efforts. Thank you very much, sir.
Yeah. Also, I would
Thank
like
you.
to thanks
I would
Misbah.
like to thank, let me give me an
Yeah,
opportunity.
please, please.
Okay. Thank you, Dr. Vikas. It was really
you.
indeed a great pleasure to have you with us, really. And within such a short moment, you accepted our invitation. I really appreciate this and hope
Thank you.
to get connected again and again. And
Definitely.
we will be able to have good discussions, and it will be useful for the students also.
Yeah.
And I would also like to thank Dr. Divya, if you're around. Thank you very much. And
Dr.
hope to see
Srinivas.
you again.
Thank
Dr. Yeah, thank you.
Dr. Srinivas, Dr. Saroj, again,
Yeah.
thanks from our side. And to our coordinator, Misbah from Critical Care Unified, she has arranged the Zoom meeting. So thanks from our side, from Apollo Hospital, Navi Mumbai. And again, we'd like to associate with all of you in the next program. Thank you.
Thank you.
Thank you so much for
very
the
much.
opportunity.
Thank
Thank you.
you.
Bye bye.
you.
Nice
Thank
to
you
meet
very
you.
much. Thank
Thank
you.
you. Thanks. Thanks again.
Good night. Good night.
Thank you.